Welcome, Dr. Lundy.
Okay, good morning. How are you? We're going to talk today about trauma resource management. I know it sounds really fancy, but show of hands right off the bat. How many of you think on a daily basis in your professional life that you do a great job communicating? One? Okay, and I bet your ICU. No, okay, it's all right. It's all right. So the reason we're going to talk about this, it's something I've been very passionate about. I have no disclosures. And the objectives we're going to do is we're going to talk about trauma resource management, or a takeoff of crew resource management, cockpit resource management, healthcare resource management. It's all about communication, depending on which term you're going to use. We're going to talk about how we as a team should communicate. Look at your own institution and think about back in times when you thought something, but you just kind of didn't want to step up and say it, that might have made an impact in the overall way the outcome of the patient was. Then we're going to talk about metrics for monitoring. Everything we do now has to be in a metric somewhere so somebody can look at it and compare you to somebody else. So we'll kind of go through it. When we talk about the history, when I started my nursing career, I actually started in a trauma center in Georgia. So I was kind of brought up as a new nurse that, you may think things, there's a time and place to say them. In a resuscitation, keep your mouth shut, do what you're told, be prepared for the unexpected. But in the big scheme of things, you're way down here as a nurse. There's the trauma surgeon, emergency medicine attending. We didn't have surgical residents at the trauma center that I worked at. And then you kind of do the hierarchy on down to the bedside nurse. Then I went over and got the opportunity to start flying. And safety and resource management in the aviation industry was a huge difference. Everybody kind of had a voice. I was told very early there's 3 seats in an aircraft, and each seat has responsibility that goes with that, including a voice. So it was a little bit of a shift for me. So think about flying for 20 years, and that's the mentality. And then you go back into the hospital setting and you realize maybe not always is that the case. There's multiple positions, but with those come varying levels of how much we want to know what you think. So I know this is probably, again, only in my shop in Florida. But when you look at crew resource management, the history of it, the aviation industry, if you think back in the 70s and 80s, think of how many commercial airline crashes there were. A lot. Where crew resource management or cockpit resource management came out of was a 1977 crash at the Tenerife airport. If you were at the STN conference, they actually had a slide that actually showed the foggy conditions. You had 2 big aircraft that were not communicating, that there's multiple incidents in there where the course of what happened could have been changed. What you end up having was 500 and something people die because 2 jetliners collided on a runway. So the aviation industry sat back and said, look at this. We're having all of these accidents. And our hierarchy currently is we have a captain of the aircraft who's responsible. We have the first officer, maybe a navigator or an additional person in the cockpit, but ultimately the captain is in charge, the captain makes the decisions, the captain is responsible, he doesn't need input from everybody else. They took a step back and started saying, well, wait a minute, did these individuals in the aircraft see things that could have changed the outcome? And as they started looking through, they realized that the system was flawed. That you may have one person who's ultimately responsible, but when you've got multiple points of view and things that could change the outcome, maybe we should look at how we communicate and how we have always done this and what needs to be changed. The evolution of it, if you think about it in healthcare, started with timeouts and checklists. It's all very adaptable to what aircrafts do. You have a flight brief, you do check sheets on the air medical side. If you run into an emergency, you're flying along at 1,800 feet coming back from downtown Atlanta, and all of a sudden, unforecast weather's there, and you're in the clouds and you can't see anything. So you pull out the check sheet, you start running through it, and it's very organized, and you're trained to do this. It's become second nature when you're an air medical crew member. As nurses, that's not something that we're generally trained in. I learned very early in my career that I thought my mama just went to one of those colleges that, they give you the sayings that you always say to your children, don't roll your eyes at me. Well, actually, I do roll my eyes, I guess. I was told very early, when you're not really interested, at least look and try not to roll your eyes. And I said, well, what does it look like when I roll my eyes? They said, just what you say. You go. And I said, I really do that? They said, yeah. So unconsciously, if I was uninterested, you get out on a scene flight and they're giving you extraneous information that matters nothing about what you're going to do for the patient that you're transporting, you should still smile and look interested. It was a trait that I had to work on because I still occasionally will get called out on my communication. For people working in the trauma ICU, you know how when you do the EHR or whichever record system you're using, if I get told one more time, this multiple injury patient popped positive for sepsis. Now they always say, okay, I'm going to give you a minute to get your I care face on because I'm going to tell you, bed 8 screen positive for sepsis. So I can regroup and act like I'm concerned about it and say thank you very much and move on. So when you're looking at why we want to do resource management in healthcare, in 2018, there was a big study that came out with Johns Hopkins. The numbers, depending on what you read, estimated between 250,000 and 400,000 errors in healthcare a year. And if you think about it, at least in Florida, I hadn't got to see any on the news out here, every other commercial is somebody trying to get personal injury from an attorney. So it's out there, everybody's looking for it. So we're under the microscope when it comes to errors. And if you think about it, look at all we have done, and more in a global healthcare sense. We've done the timeout process. We're looking at check sheets. Is everybody agreeing this is what we're doing? We haven't always moved that outside of a global perspective into individual areas. So when you're looking at the trauma system, the critical care system in hospitals, we still have a lot of room for improvement when it comes to how we communicate. So in reviewing causality of the 250 to 400,000 incidents that occur a year, over 50% of those can be tied to ineffective communication, lack of communication, or lack of someone who knew that this was wrong stepping up and saying, hey, let's stop, let's regroup. How many times in your own institution, nurses were really bad about, well, if I had done that, I knew this wasn't right. But do we always step up and say those things? Probably not. And some of it is hierarchical in the way it looks at in your own institution, and also the way we've been brought up as far as nurses go. When you're looking at elements of resource management, essentially it is broken down into situational awareness, speaking up when you need to speak up, and when you're speaking up, how many times in your own institution have you said, oh, I think we need to do X, but we've not addressed it to anybody? I've sat back and looked at video recordings of the traumas, and there's a lot of discussion, but nobody's been owning who needs to do what. We're not good about saying, Dr. Smith, I think this. We're saying, well, does anybody think we should give blood? Anybody? I start thinking about the Ferris Bueller's Day Off. Bueller? Nobody answers. So when you're looking at it, the continuing process of it is looking at your own organization and figuring out how do you communicate, and is it effective? How do we start? Well, I grew up during the time with older surgeons that didn't always take kindly to suggestions or questions. I think that culture has changed somewhat over the years. Even in my own organization, we still struggle with some who a question should not always be viewed as challenging. It's simply clarification. And so we kind of have to work with it. So we need a commitment from leadership, and it has to be an organizational commitment. You can't do resource management in trauma if you're not doing it in your other critical care areas, because it's a process that should continue. Example, if you're doing it in the recess bay and it doesn't carry over to the intensive care unit, then you're missing a point there and a component of it. At our organization, traumas, once they start in the system, they start in the trauma bay, they go to CT scan. If they're an ICU player, they never come back. They go straight CT, ICU, IR, OR. If they're going to be a med-surg or there's a bed problem as far as availability, then they will go back to the emergency department, but they never go back to the trauma bay. They go back to a regular ED room. So when you're looking at how to develop your process, look at all the points of entry where a downfall in communication could actually be disruptive to the patient care. In our morning checkouts, the APPs are there with the trauma surgeons. We also have what's called trauma nurse leads. One is ICU background, one is ED. Those are the resuscitation nurses. They come to morning and evening sign out. So they're aware of everything that's going on within the service, which makes it much nicer for communication at night when the T&L gets called about an issue on the floor. Then as they go up the chain from the APP to the surgeon, the information, everybody got the same information at shift change. And it also gives an idea of what's going on in the unit. When you start looking at the development, look at how you're going to integrate this into your system that works now. There's not a set plan, but it's all about establishing how you want to do it. And then it starts with the team assessment. We don't always do well when it comes to self-assessments, but this is an important point that you have to look at what you do good and what you don't. Where can you improve and where not? One of the struggles that we had as we started looking at trying to do this is you have two really big components. We don't have surgical residents. We have residents, but not surgical residents. We have EM residents. So when you look at it, you got the emergency medicine attending, anesthesiology attending, and a trauma surgeon attending that respond to all level 1 activations. Add on to that an ER resident, a trauma APP, and a nurse anesthetist. So you essentially got 6 people in there, provider level people, trying to work towards a common goal. Could you see where that would be confusing if effective communication hadn't been established up front? Again, probably only in my place, but emergency medicine often likes to try to take the lead. And then anesthesia, of course, airway. Then you have the trauma surgeon who's trying to look at the overall picture. I was recently invited to participate in an RCA representing critical care. And without getting into a bunch of the details of the case, it was very evident from looking at a timeline that communication was the problem. There were multiple points. I think I stopped counting at 10 points along a timeline where the outcome of what happened could have been changed. And it drew back down to nobody was communicating. And when they were communicating, they weren't communicating what was needed. And if you think about even in your own institution, a classic example, I got a call, I was on call the other night, and I get a call at 2 a.m. The patient says she has heartburn. I said, pardon me? The patient has heartburn. I said, it's 2 a.m. I said, is it something that needs to be done right now? Well, no, she woke up, she's back asleep now. Okay, is that something that's important at this particular point? No. What was important at this particular point is to let me know that her SVV was 22. That would have been important. So knowing what we need to communicate, it's along nursing, we have to kind of own that and learn to train our people to do that. So as we continue, how do we start it? Well, figure out where your biggest impact is. Pre-briefing, ours starts with sign out, check out. So everybody kind of knows what's going on with the service that day, what the staffing looks like, what a bed availability looks like, and who's going to be on call for what if there's any kind of issues. But it also starts in the trauma bay or the ICU. If you get the opportunity, a good pre-brief is when everybody responds, you get them in there, and everybody talks about what the plan is. You know, most often when we get patient reports, whether they're coming to the ICU or to the trauma bay, we already have an idea of what we need to be doing. We need to communicate that openly. And also identify roles. Who's going to do what? It saves a lot of trouble if you got anesthesia, emergency medicine, and trauma on who's going to be doing what, airway lines, this kind of stuff. So start with a sound pre-brief. And a good way to start is to put the patient information on a whiteboard. When I used to fly in the Atlanta area, which is where I spent about 12 years of my flight career, there's a big level 1 trauma center in downtown Atlanta. It's a zoo. There's no other way to describe it. I've never been in a place like that. And when you would go in, there's 25 people, everybody's talking, and by the time you leave, you've given patient report 5 times because people are drifting in. Instead of the one person that needs to hear it, you're giving multiple patient reports. And I can just about tell you that by the 3rd report, I was probably leaving out information that was really good in the 1st report. So you have really one shot to get this and get it done right. So when you establish your pre-brief, look at what components you want. Is equipment available? What is your bed status? Is CT ready? Who's going to do what roles? And get a kind of a pattern of what's going on with our 2 TNLs. They alternate who's scribing and who's not scribing. So it's another thing that needs to be decided beforehand. And another idea is when you get your patient arrival, instead of it being chaotic and good information missing, so everybody on the team is hearing what's going on, you should do a 90-second pause where everybody is quiet, EMS is allowed to give their report, tubes are verified if the patient is intubated, before everybody jumps in and starts doing what they're supposed to do. That way, all the information is there, it's answered, and it's heard by everybody in the room. Remember back in school when you used to play the game telephone where you'd start by the 8th or 10th person, how different the message was? Well, can you imagine here if you've got 5 or 6 people talking, EMS or air trying to give a report, and you're the scribe and you're trying to pick out pieces of information. And we want our documentation to be as accurate as possible. We also want a clear picture of what's going on with the patient. So having that pause kind of gives everybody a reset to start on the same sheet of music with the same information. So you get your patient, you go through the resuscitation, you go to CT, IR, wherever, and you end up in the ICU. Once the patient is tucked in or in the ICU definitive care area, it's a good time to pull the team back together. And here, generally, you're only pulling the trauma team. So it's the TNLs, the APP, the trauma surgeon, and kind of debrief what went well, what didn't go well. We should always be looking to improve. We actually have a form that they debrief on, and it goes to the PI committee. So if there's things like, oh, the ultrasound had been taken out of the trauma bay. I know that never happens anywhere else. Yeah. Ultrasound was taken out of the trauma bay. We don't know. There was no fentanyl in the Pyxis in the trauma bay, or, these kind of things. It's an operational issue that we can address doing pre-brief. If we're doing it, instead of coming up at the next operations meeting going, I had 3 trauma activations last month where the ultrasound had to be hunted. Nobody knew where it was at. Instead of it being an ongoing, let's try to catch it up at the end of the month, do it in real time. Do it at the end of the resuscitation or the debriefing, and try to figure out what you can do to make it better. So when we're looking at how we can incorporate this in ongoing monitoring, if you follow STN, there's a lot of discussions on the board about video traumas and legalities behind it and who gets it, who can see it, and who can't see it. So I don't know that there's really a definitive answer, but it's amazing when you've been in a trauma activation and then you sit back and watch it on video, how very different it seems when you're watching it versus participating in it. It's a great opportunity to learn from how to communicate. I had a video review that we were watching a few years back, and I was actually involved in the trauma. I was the director then, and I actually had went to the activation. And there were multiple points on there where I was hoping that we kind of changed. We got tunnel vision, plain and simple. Multiple arrivals at the same time, and in level 2, our surgeon is in-house, but the backup is on call. So the backup was coming in. It was the time of the evening where there were only 2 EM physicians. So we had 4 patients arrive, 2 of them were critical. One, I think we just got tunnel vision on what we wanted to do. We wanted to embolize the spleen and trying to manage the other patients. Things continue to deteriorate. We missed some benchmarks as Dr. Wilson was talking on blood pressure. Okay, it's only dropped 2, it's only dropped 3. End result is the patient ends up not having a great outcome. And when we go back to review and talking in the open debrief, everybody was like, oh, well, I thought we should have given blood earlier. I thought we should have just went ahead and went to the OR. A lot of thoughts came out, but during the actual event, nobody stepped up and said anything. So were we complacent as nurses? Should we have spoke up? Yeah, we really should have. And this is a culture change for us. Most of us that are older, the trauma surgeons are here. And when you question them, respect has to be given. And that's where some of our younger nurses struggle. I know y'all don't have catty nurses where you work at, or petty betties as we call them, but we do. And it's all how you approach a physician when you're talking to them. Everybody has to be respectful, but you should have the relationship where you can say, hey, what about this? I'm thinking this. Are we sure we want to do this? Are we sure we want to wait on IR and not go to the OR? You got to kind of get that culture, and it's a change, a big culture change. In a community hospital, it's probably more so than academic. I think the academic medical centers have done a lot in how they communicate and equal members of the team and this kind of stuff. In the community hospitals that are not academic level 1s, it's still struggle with some of the older physicians in the group and nurses not knowing how to be professional and address what their concerns are. And it's all about being respectful with it. You can get a lot done. I got one that I work with, and she used to tell them, the new nurses, it's all about flipping your hair and going, well, could it possibly be? She goes, act dumb, they love it. I disagree with that part. But I do think that we should incorporate resource management and effective communication in the ICU and in the trauma bay. And we as nurses a lot of times are the driving force behind that. The physicians have a lot of other things on their plates, and if we work on establishing the process, pushing it forward and being active participants, ultimately that's what's going to be best for the patients. So looking at putting it in the PI process, this can be done using your post-debrief forms. You can include with your video reviews, or just in your open discussions. Was there anything we could have done better communication-wise? And the ongoing development and revision portion, this is a fluid process. It's not something that you put in place and dust it off and leave it alone. Is how we communicate with each other for the betterment of the patient is an ongoing thing from here to eternity. And we always can get better at it. And we have to focus on that. If, as nurses, you know, we've always been taught, you know, you hear all the time, oh, nurses eat their young. One of the older nurses I work with, she goes, yeah, that used to be true, but the ones coming out now aren't quite as tasty. And I said, I'm going to use that at a conference that I'm coming up with. I said, I won't use your name in case they're videoing somebody that might know you, but I will use that at a later date. And if you think about it, as the nursing force is changing, we have a lot of young nurses. We're still getting past the, well, they hurt my feelings. I didn't know you had feelings, okay? When I was the director, I got called to my CNO's office, and she goes, one of the nurses came, and she was very upset. I said, okay. She goes, she felt like you hurt her feelings in the trauma bay. And I said, I know where this is going. Is this the one that I said, there is no crying in trauma? And she goes, that's the one. You know, as you get older, you try to get more warm and fuzzy. I'm not quite there yet. But in your ongoing revision, think about the newer nurses and people who don't know how to communicate and include them in the process. I mean, let's face it, the nursing population is getting younger. You know, I have probably 50% of the night shift that I work with is 26 and under. Because everybody wants to go to days. I don't know why. Every time I have to work days, first of all, I hate getting up. Second of all, way too many people in shirt and ties walking around. Way too many. You know, and then the doctor's lounge is always full. At night, you can just go in there and get what you need, you know. So nights has its caveat. So when we're looking at our summary, doing effective team communication can reduce patient error. If you think about it, having a voice, everybody being on the same sheet of music versus Monday morning quarterbacking where you go, well, I knew that we were going down the wrong path, but I didn't say anything. We should say something. Communicating not only in the trauma bay, in the ICU, in healthcare in general, is the pillar for our highly functioning teams. We want to function at our best level. We all have room to grow, and we should continue to strive to be the best we can when it comes to communication. Team development is a dynamic process, and it takes participation from everybody. You've got senders and receivers all throughout your resuscitation. They both need to be able to react in their appropriate manner. If you're giving the information, you want to make sure it's clear, it's directed to somebody, and that there's acknowledgement of it. If you're receiving, you need to listen. I know as nurses, we think we're good listeners, but can you think back during your career at times where maybe you, I'm guilty. And then you get to the end and you think, what did she say? Was it important? Probably not, or I was distracted. Give it your undivided attention. For the safety of the patient, effective communication, continuing to grow is the way that we're going to reduce the errors, especially in the trauma bays. Thank you.